very, shall we say, she's been very, very flexible through all of this. She has worked with Three Oaks Hospice for 6.5 years. Before that, she was a case manager and discharge planner for the inpatient rehab patients of a skilled nursing facility in Dallas. She is a native Texan, married 33 years, has 2 adult children. Her passion is educating and assisting people in their most difficult times. Thank you for being so patient, Lisa.
Of
and
course.
Go ahead and take over.
All right. Well, thank y'all for having me today. It's a pleasure to join you. And sorry if I put on and off my glasses. I'm one of those that just buys grocery store glasses. So anyway, so I just wanted to kind of clarify what hospice is, what palliative care is, what the services entail, and when you should seek the extra care through hospice. It's a passion of mine. I have family members that have been on hospice from the very beginning, that hospice was available. So let me just kind of start with a history of hospice. Medicare started recognizing hospice in the 70s. And when hospice first started, it was mainly for cancer patients. And so with hospice, you cannot be seeking aggressive treatment. So in order for a person to be eligible with cancer, you can't be seeking chemo, radiation, those life-sustaining type treatments. So with cancer patients, when they admit to hospice, usually it is toward the latter stages of life. In the 80s, Medicare and all the other insurances as well, but I'm just going to be kind of addressing Medicare, recognized all these other illnesses that there's not a cure from. So, and one thing to clarify, I'm not a clinician, I'm not a nurse. But so I'm going to be speaking just kind of in general terms, in layman's terms. So in the 80s, Medicare added heart issues, Parkinson's, all types of memory issues. So that would include memory issues from alcohol abuse, memory issues from Alzheimer's, Lewy body, dementia, anything like that. At the end of stage, you would qualify for hospice. And a lot of people, I think, get the misconception that it has to be added just right at the very end. But there's so much that you can gain through the hospice care, especially if you are at home with your loved one. So hospice care can come into wherever the patient is who qualifies. So whether that's at their home with family, whether it's in a residential care home, whether it's in a nursing facility, an assisted living, it's extra medical attention coming to them to help with their care. And it's mainly about symptom management. And so, for instance, a lot of people have a misconception that you can't still stay on your medications like your heart, your blood pressure medications or that kind of thing. And that's not true. An easier way to think of hospice is that we are going to aggressively treat the symptoms. So whether that symptom is breathing issues and we need to provide oxygen, whether it is wounds, wound care, we would provide that. Whether agitation, anxiety, hallucinations, we would address all of that. So it's more frequent medical care coming to the person with the disease that is non-curable for someone who's stopped seeking aggressive treatment. And so the people that are available, well, let me back up too. The reason that Medicare provides this care is it saves them a lot of money. So if someone's going back and forth to the hospital, and then of course, when someone goes to the hospital, they run all kinds of tests, even though, maybe they're not going to find out anything, or even if they do find out, is there something that's going to be done about that? So anyway, it saves them money to have the medical attention come to them wherever they are. So the team of people that are available through hospice care is an RN case manager, and she would come. Our company has them go at least twice a week just to check in. Medicare requirements are once every 14 days, but my company feels like it needs to be more often than that. So we go at least twice a week to check in, check the blood pressure, order medications, document what's going on. And so having a person seen more often and more frequently, we would be able to nip things in the bud before they escalate out of control. For instance, like a urinary tract infection, which is quite common. And so if our nurse or our aide goes and has an inkling, there's an odor or something that there might be a urinary tract infection, they're going to address that up front, because we all know that unmanaged urinary tract infections can quickly escalate out of control. So the RN case manager would see them and kind of be the team leader. The aide or a CNA is available. My company does 5 days a week. And so that person's job is to come in and help bathe them, clean them, help them get ready for the day. They're not paid caregivers, so they don't stay the entire time. It's just they have a job to do, a checklist to check off. So that would be, giving them a shower if it's shower day, brushing their hair, brushing their teeth, changing the linens, that kind of thing. Once they complete their tasks for the day, then they go off to the next patient. Also available would be a social worker and a chaplain, a bereavement coordinator, volunteers. We have a fabulous volunteer program. So for instance, if someone is going to benefit from just a visitor coming and maybe reading to them or something like that, then we would provide that. Pet therapy, all those things. So it's really addressing mind, body, spirit of not only the patient, but the family. A lot of times, the family needs the education of where their loved one is in the disease process. And so that's a huge, especially if the person is not able to communicate, the patient is not able to communicate, that's huge. Because as we know, especially with dementia, there are 7 stages of dementia. So we don't really see people until they're in the 6th or 7th stage. And again, each person is different. So the nurse will educate you on where your loved one is. Each person is different as far as how long they're in each stage as well. So that education, that reassurance of what's going on, what's happening. The other thing, hospice is a 24/7 emergency. We're available 24/7. So if in the middle of the night, your loved one is doing something that you're concerned about, you have a number and you can reach an RN directly, immediately, to get a question answered or to have someone come out, depending on what's going on. So it's immediate response. It's to try to keep people from going 911 to the hospital if it's appropriate. Now, it doesn't mean that they can't go to the hospital. As we all know, with dementia, memory care people, a lot of times they forget they can't walk. And so they get up and have a fall. Unfortunately, that happens quite a bit. If someone has something that's broken or they need stitches, of course, take them to the hospital. But you would call the hospice company and say this is what happened. I'm calling 911. The hospice patient would take them off service at that point when they're admitted to the hospital. It's a billing issue with Medicare. So when that person is admitted to the hospital, you want Medicare to pay for the hospital stay. And when they come back home, when they're discharged from the hospital and they come back, then hospice would resume and the person would be readmitted. So it's not a all or nothing. The other thing with hospice, people sometimes get better and they graduate off of hospice. This happened to my own dad who had CHF. And so once he went on hospice and he was being seen more often by clinicians, being cared for a little bit better, he actually improved. And so we took him off of hospice. He went back to having rehab therapy, physical therapy. And then as things progressed, then he went back on hospice. So it's a fluid type situation. Whatever is best for the patient is what we would do at that point. And so with hospice, it's billed under Medicare Part A. If someone has a Medicare Advantage plan, it always reverts back to true Medicare Part A through their Social Security number. So it's 100% paid for if they qualify with a diagnosis. It's 100% paid for by Medicare Part A, and it would revert back. If they're under 65, then we would just need to run their insurance plan and see what type of plan they have as far as hospice care. Some of the things that hospice does is really help treat the person mind, body, spirit. So if we can do things that the person enjoys, then we're going to do that. We had a 99-year-old person on service who used to be in the Air Force, and he did have dementia, but he could still ambulate and he could still get around. And his wish was to fly a plane. So our volunteer program, we found someone and took him up in the plane, and he had the biggest grin on his face. He also had some heart issues. So not only the dementia, but some heart issues as well. But he had that day, that moment, it was wonderful. And so anything that we can do to help that person live their best life. A lot of people have the misconception that hospice is giving up, and it is absolutely not. It is providing the best care, more frequent care for the family, because I can't tell you how much it was a help for me personally when my dad went on hospice, and it wasn't all on my shoulders anymore. I could lift it off of my shoulders and actually have some help and guidance through the process. So it's wonderful to have that. A lot of times people want to know what the end of life looks like, and for everyone it's different. I can tell you that, excuse me, just like our bodies were made to be born and that whole system, our bodies were made for the end and to pass. So our job is to have that smooth transition. Some of the things that you might see at the end, as towards the end of life, is the person would be sleeping more, not eating as much, sometimes hallucinating, and people will see their relatives who have passed on.
My phone shut down.
I'm going to take a drink of water, sorry.
And then so I got it again.
Okay.
Can
The
you,
other things is
can you
breathing.
mute if you are having conversations? Excuse me, Lisa. We can hear a little background noise. Thank you. We will open up later.
Okay. The other things is the breathing. 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 Okay. The other blood pressure, breathing differences, all of those things are end of life. And it's very common, even 6 months before the end of life, to start seeing their relatives who have passed on. It's very common. Excuse me, I'm so sorry. The new thing is palliative care. And so I just wanted to bring that up a little bit. The word palliative means comfort. So it really means the same thing as hospice. And Medicare has just started recognizing palliative care as a billing slot within the last few years. And so what that looks like, community-based palliative care is also billed to to insurance, whatever that might look like, Medicare or their other insurance. And our palliative care program is a palliative physician going to the home. So with palliative care, it's billed under Part B Medicare. And that means that you can also be getting home health care. You can be getting therapy through home health care. Excuse me, I'm so sorry. So that's one thing to ask if somebody says palliative, because a lot of times people say palliative and they really mean hospice. And so it's been an interchangeable word for a long time. So you have to clarify, what do you mean? What's the billing source? Is it under Part A Medicare or Part B? So hospice and home health, which is the therapy end of it, are billed through Part A Medicare. Palliative is billed through Part B as an office visit. And so it's really just adding another physician into their physician group. So you can still be seeking aggressive treatment like chemo, radiation, dialysis. You can still go out and see your other physicians. It's just another physician added to the group, but they do make house calls. So they would go to the person who has the disease, the non-curable disease, and their role really is to kind of coordinate the care between all the physicians. So the oncologist, the cardiologist, the primary care physician, neurologist, all of those physicians remain in place with palliative care. And the palliative physician is just added to the group. Because if you think about it, with all these other physicians, really, they're a lot of times so focused on their particular job, they don't really give you the big picture or the big prognosis. So that is a job of the palliative physician. Ours is a woman, so that's why I use she, but ours, she would go out, she would communicate with all of the other physicians. She can write pain medications or symptom medications if needed. But she coordinates the care. She talks about the prognosis of what's going on with the patient, with their disease process, and really gives them a clear picture, talks to them about their goals of, what their desires are for end of life, what they want to have happen. Someone can remain on palliative care throughout their whole disease process and never go on hospice. Sometimes they transition to hospice, but if they want to still seek aggressive treatment, continue to see all of their other physicians, this is a good way to introduce and talk about their goals and end of life. So again, it's billed to Medicare or their insurance, just like a clinic visit would be, a doctor visit. Back to hospice. With hospice, Medicare requires one physician to be the attending. It doesn't mean that those other people will be informed of what's going on. My company sends a fax update every Tuesday to the oncologist, the neurologist, whoever wants to stay involved. It's a billing issue with Medicare. You don't take the person out to see all those other physicians. Just one physician is in charge. So my company, we allow any physician to be the attending. So if the primary care physician, the oncologist, if they would like to be the attending, we welcome that. A lot of times those physicians just don't have the time. They want to know what's going on. That's why we fax the updates. They can call. So if that happens, then our medical director would be the attending. And so our nurse would report to our medical director. Whoever is the attending is who our nursing team reports to and gives the information. That doctor is the one that writes the prescriptions if needed, all of those things. So whoever that is would need to be available. Sometimes those other physicians are just too busy, but there's nothing that's wrong with them talking on the phone with the medical director or whoever the attending is. And we like to keep people updated, the doctors updated on what's going on in that case. So the difference, again, palliative care is not an emergency situation. It is a scheduled doctor physician visit Monday through Friday, 8 to 5, whatever the time frame is. It's a scheduled appointment. So if there's a crisis in the middle of the night with palliative care, you would still call 911. You would still take your loved one to the hospital. With hospice care, it is a 24/7 emergency situation. So you have that number to call anytime, day or night, whether it's just a question or we would need to send someone out. It doesn't matter. So we want to be there for your support. With hospice, again, you get all of those people, and also Medicare pays for any type of equipment. So if your loved one needs a hospital bed or a wheelchair, or walker, potty chair, anything like that, we would provide and send out the very same day. Also, any type of medication that is related to their diagnosis would be paid for in full through hospice. And also the throwaway type supplies. So gloves and wipes, incontinence supplies if needed, wound care supplies, all of those throwaway type supplies would be provided by the hospice company and delivered to the home. Usually the aide or the CNA is the one who brings out the throwaway type supplies. So it is a help, a relief. I think with dementia, and I'm not sure what everyone's loved one is suffering from, but with dementia, the earlier, and really any type of disease that you're not going to be cured from, the earlier you add hospice care, the better, not only for you, but for the patient, because they're going to be seen more often, they're going to get more care. With dementia patients, if they're an easy way to think of it, and we all know that with dementia patients, the brain is going backwards. And so in the end, they're more like an infant and need total care. But we see most people are able to be admitted to hospice with memory issues in stage 6 or 7 when they are needing pretty much total, you have to really watch them. So even if they're walking around, but you have to cue them to eat, or you have to really watch them because they're a major fall risk. They would probably be appropriate. Now, A nurse would have to evaluate them and make sure they are. But if your loved one is, not eating much, sleeping a lot, incontinent, then you can pretty much guarantee they're probably hospice appropriate. And what a relief that is. I had my grandmother had Alzheimer's, and it's a horrible disease for the family, because you have to keep in mind that it's the disease, it's not your loved one. They're not the same personality. You get the brunt of their wrath. So they don't understand, and you can't reason with them at that point. So they're mad, they're angry. It's just not, it's horrible on the family and the caregivers, because they're having to take that wrath and that anger. Really, they're grieving for themselves because they can't remember and they're mad about it. And, it would upset me too, but we have to think of ways out of the box to divert their attention, to really gain their trust, to that we're doing the right thing for them. The main thing that we all want is we all want to know that we're loved and we want to be safe. And so repeating those things, when I worked in the nursing home for all those years, it was such a horrible thing for the family who, the family may have been there 30 minutes before, and their loved one is saying, my family hates me, they never come visit me. It's just, they're not, they don't understand. So really teaching the family, this is not your loved one like you knew that person before. This is a whole new, it's the disease taking over, and it's painful, it hurts. So I've been through with my own family cancer, Alzheimer's, heart disease, and Parkinson's. So I've seen the gamut of the disease, and nothing's easy. But what I would like to say is to, while you're still able to talk to your loved ones, let them know what your desires are, what your wishes are, what you want your end to be like, at what point. So I had to put a plug in for that, because I think so many of us wait till the last minute. Oh, I don't need to do that. And you don't want to have to make decisions when there's a crisis. So talking to your children, letting them know what your desires are, what your wishes are, is something that's very important. I don't know how we are on time. Should we stop, Xanda, and ask for questions, or? I can't hear you, Xanda. Xanda,
Sanda, you're muted.
you're muted.
Okay, here we are. I
There
have a
you go.
couple of questions from the chat. And this person says, I've often read that as soon as Parkinson's disease is given, that the patient should enroll in palliative care. Yet our local organization, which is a part of hospice, only enrolls when the patient has 2 years or less to live. Can you comment?
Okay, so I think the important thing is to differentiate the word palliative and hospice, and what they're actually telling you is. So with hospice care, the guideline is, could that person pass away within 6 months? And so obviously we have patients on service that will live for 2 years or 3 years, but they still have the disease that is qualifying them for care. So with Parkinson's, if the person is needing assistance, but they're still able to get to their doctor's offices, then palliative, the true community-based palliative, would be the better solution, because the palliative physician can kind of look at all of through the neurologist, through the primary care, give you a better example. And maybe the palliative care doctor only visits once a month or once every other month. You know, but they would definitely be eligible for community-based palliative care. Now with hospice, a lot of people get hung up on that 6 month or less, like we said. It's a kind of an arbitrary number that Medicare came up with, but is there the possibility that the person could pass away within 6 months? Well, there's always that possibility if they are having, you know, a disease process coming on. So, but Medicare requires someone to be recertified for hospice after the first 90 days and then after every 60 days. So it's the hospice company's job to send in the notes to Medicare to update, and you'd never go off of service if they still qualify, if they still need the care. So I think it's really differentiating what palliative care means and how is it being billed. Is it being billed as an office visit, or is it through Medicare Part A, which really that means hospice? So sometimes people call it palliative care when what they're really talking about is hospice through Part A Medicare.
Okay. The next is a caregiver. It's not a question, more of a comment, but certainly want your comment about this. This caregiver writes, why do we constantly, and I think it means confuse hospice and palliative care? They are so different. Hospice requires within 6 months of anticipated death. Palliative care could be brought in 30 years prior to death for Parkinson's disease. One is about quality of life and the other is quality in the end of life. I wish we could separate the two. And then goes on to say, can we just stop talking about hospice for Parkinson's disease patients? Do you have comment?
So palliative, the word palliative is really the umbrella. It means comfort care. And under the umbrella of palliative care, you would have hospice, home health care, chemotherapy, radiation, all of those things that would provide comfort. And so in the past, when Medicare and the other insurances did not recognize palliative as a true billing source, palliative really kind of meant the same thing as hospice. So the term hospice is nothing to be scared of or concerned about. Again, yes, palliative is adding another physician to the other physician groups. So the neurologists, all of those other ones stay in place. You can still be seeking aggressive treatment through palliative care. You're just gaining a palliative physician who comes out to the home. That's it. With hospice care, you would have all of the others. And yes, they do require a doctor saying that there's the possibility of someone passing away within 6 months, but there's also the possibility that they would continue on living. So really, it's the need of the patient. If they're still getting around, getting to the doctors, absolutely, you need palliative care. You do not need hospice. If they're pretty much homebound, and not to say that they have to be homebound, we want them to get out and do things. But if they're needing total assistance with watching them, caring for them, redirecting them, then they probably would qualify for hospice. Does that make sense?
Okay. I'll direct the question if it pops up again. Another caregiver makes the comment, there are not 7 stages with all dementias, such as Lewy body's disorder. Comment?
So if you Google 7 stages of, or the stages of dementia, you'll get a variety. I go by the 7 stages, which kind of really just simplifies it a little bit because I'm not a neurologist, I'm not a clinician. Lewy body is a terrible disease, as we all know. But, you know, dementia with alcoholism could be a very similar, person could have this similar hallucinations and that kind of thing. So it depends on where the disease is in the brain as far as how they classify it. But basically, the basic understanding is it's the brain going backwards in time. And each person has their own specific journey, no matter what you're calling it, what you're labeling it medically, it's the brain going backwards. So at the end, they end up needing total assistance, just like an infant would. So if you have specific questions, I think asking your neurologist and talking to them, I'm all about, you know, educating yourself on the specific needs of your loved one, because again, each person is different. But you know, with memory loss, it's going backwards with the brain as far as needing care.
Okay. Another caregiver. My mother has dementia and is being cared for in my brother's home. How do we begin the process of getting connected with hospice and finding out when she can be admitted into hospice? I think you addressed that, but it certainly can be so confusing. So
It does, absolutely. Check with her primary care physician or her neurologist. What we would need to do from hospice is have a history and physical and a recommendation on evaluation from a physician. And so we want to see the big picture of what's going on, how long she's had it, that kind of thing. And then we would have a nurse go out and do an evaluation. So you can have the evaluation done at any time. You would just need to speak with your physician and ask what their thoughts are. You know, a lot of times physicians are slow to put that out there, but if you are persistent, you are their advocate and you say, I need help. I can't tell you for my own, how much of a relief it was for my own family member to be able to get that help coming in. It's just such a weight off of your shoulders, and it's just a wonderful thing that is available. And so many people don't because they're worried about that word.
mhm. If anybody has other questions, please just put that into chat. I have a question. Whether it's hospice or palliative care status, that is still covered under Medicare Part A. Is that correct?
I'm sorry, say that again.
If it is, whether it's hospice or palliative, it's still covered under Medicare Part A. Is that correct?
No.
Okay,
So,
I think that would help some clarification.
yeah, so hospice is under Medicare Part A. It's 100% covered with the team of people, the equipment, the medications, the supplies. It's under Part A. Palliative is under Part B Medicare, and it's a physician, it's billed as a physician visit to your home. So whether the person has Medicare, which it would be under Part B, you can have palliative care and home health care at the same time, because home health care is Part A, and you get the nurse, the physical therapist, the occupational therapist, the speech therapist coming to your home if needed. And the palliative physician would just be billed as an office visit. But you cannot have, for the most part, generally, home health care and hospice at the same time. One is a getting better, which is home health, and one is a dealing with the symptom control, the symptom management.
Okay,
That
I think
makes sense?
that's real helpful because it does get very confusing.
Yeah.
Another caregiver writes, my husband is on hospice, and it includes inpatient respite for me. his full-time caregiver, who is so incredible for me. Oh, I think she's saying, and his full-time caregiver, who's so incredible, allows me to keep him home. Does
Yeah.
palliative care include respite?
Right. No, that's a good question. The answer is no. Palliative does not. So there are different levels of hospice care. The one we've been talking about is routine care. It also includes respite care. So for 4 midnights, 5 days, if the loved one has to go out of town or just needs a break, then we would place that person in a skilled nursing facility that we contract with for those days. And that can happen. It just really depends on the need of the family, but that would be respite care. So we would pick up the person, whether it's by wheelchair van or stretcher, take them to the skilled nursing, and then bring them back when the loved one gets out of home or has a little break. But it's for 4 midnights, 5 days, every so often. And there's not really a set time on that. But the other one is crisis care. And so if the patient is having a symptom that the nurse deems as crisis, and that could be unmanaged pain, it could be trouble breathing, it could be restlessness, anxiety. An easier way to think of it is that if the patient is having to be medicated for whatever reason every hour or every 2 hours, then as a hospice company, we would provide a nurse to sit bedside and administer the medication until that crisis is over. And sometimes it's just, an hour or a few days, not more than an hour, but a few days, and then they get over whatever was going on and it goes back to routine care. Not everyone at the end of life is going to qualify for crisis care. Our goal is for the person to pass peacefully and not ever need to have that intervention. But with a lot of diseases, pain is an issue, or breathing and that kind of thing. So it is necessary to have a nurse sit bedside. The one thing I do want to say, hospice care is paid for with all those things, but Medicare does not pay for private duty sitters or just someone to be there. We do come in and we have a job to do, and we make sure we do that job very well, but we're not there to just sit with the person unless there is a medical need. So I just want to make sure we clarify that.
Okay. There's a couple other comments, but Lisa, you made the comment before as you were talking about, we do this, we do the assessment, whatever. Folks, Lisa is here as a subject matter expert, not necessarily about just her own company. And so when she says we, she's talking about the standard practices of hospice and palliative care companies, correct?
Yes.
Okay.
Exactly.
Also, you talked about inpatient respite. Many of our listeners, some of them are in rural areas or they're in areas. Can we assume that every community has some type of an inpatient respite facility?
And I guess probably not, because it does have to be a skilled nursing facility.
Mm-hmm.
It
So
can't
if
be
it's
an
a
assisted
skilled nursing
living.
facility,
Yes.
but do they?
There has to be 24/7 RNs in that facility. And typically, it can't be an assisted living or anything like that. It has to be a skilled nursing that the hospice company has a contract with.
Okay. And do these skilled nursing facilities have to take inpatient or take people
No.
on? So that's a business decision on their own.
Yes.
Okay.
Yes. And
That's
they may
helpful.
be full, if they're full and don't have a bed available, or the other thing during COVID that happened quite a bit is they didn't have 24/7 RN coverage because of the nursing
right.
shortage.
Okay. And do you, in terms of hospice and respite, do many hospice work with Area Agency on Aging, sometimes, or Alzheimer's Association. Sometimes they'll have funds for at least temporary respite care. Can you talk about that a minute? And then we have another question here.
So we definitely would coordinate with, Alzheimer's Association and those kinds of things, but our services are paid for by Medicare. With the Alzheimer's Association and those other ones that are nonprofits, we would just need to work with them. So our volunteer coordinator, our bereavement coordinator are such excellent resources and would guide the family if they need help with support groups or whatever is going to benefit the family and the patient. Does that answer that?
Mm-hmm. I think you've already answered this question. Is that routine care, the respite care provided under Part A hospice program or under Part B palliative? And you've already addressed that,
Yeah.
that palliative is not, it would be through the medical care, the physician care.
Yes.
It would be billed but again, a hospice company has a coordinator, as you speak about, that can help advise families about that.
Right. Absolutely.
If you were to sum up your last comment, if you wanted to come up with 2 or 3 things that you think are just essential, how would you like to close out our session today?
I think the main thing and what was helpful to me is not being scared of the word hospice. And a lot of people have a big misconception about what hospice is. Be open to an evaluation. And the sooner you add hospice when it's appropriate, the better, because it's just such a relief. Like I said, with my own family, and I see it every day. It's such a help for not only the patient, but for the family members and the caregivers.
Okay.
So talk to your physician, talk to your primary care or whoever, and just be an advocate for your loved one, because we've all got to have an advocate. That's huge right now.
One more question that just came in. Is assistance with bathing considered occupational therapy if the patient cannot bathe or shower without assistance? And I'm sure she's talking in terms of when they're in hospice care.
So hospice care provides a CNA or an aide to do showers. She would come in and change the linens, brush hair, brush her teeth, help someone basically get ready for the day. And so she has a checklist that's made up by the RN case manager under hospice. And yes, so she would do all of those jobs. Maybe shower day is Monday, Wednesday, Friday. So she's going to be there a little bit longer on those days than the non-shower days when she just gives a bed bath or kind of basic cleanup. So, but if the person needs a shower every day, then they're going to get that. So, it would be on a case by case, but yes, that is occupational therapy, and it's done by the CNA for hospice.
Okay. And this caregiver said, I think of hospice as a gift. The patient and family can really benefit from it. I think sometimes we wait too late to mention it, which is probably a good place to end. I have one comment. This may be helpful to everybody listening in before we sign off. Earlier, someone made the comment that having all of the video was distracting. And for those of you, for that person, I'm sorry, we did not address it when it came in. If you go to the upper right-hand corner, it says view. And if you select speaker, then you'll get a ribbon of a few people at the very top, but primarily your screen will be the speaker, or you can hit full screen and get that. So just so you know that gallery is what typically is what's being displayed when we all sign in. Okay, I think I can answer these through chat. Again, Lisa and everybody that's listening in, thank you very much for your patience, your understanding, your flexibility, everybody. And we do appreciate those of you that have been waiting. We we'll be sending out an email about that there will be a recording of this. So those people that thought probably the whole show wasn't going to go, that they will have a chance to at least listen to the recording. Thank you again, everyone. Thank you, Lisa.
Thank you
Take care,
so
everybody.
much. I really appreciate it. Thank you. Have a good day.
You too. Bye-bye.
Bye.